This episode of the Jerry Pal Podcast is sponsored by Indiana University Health's Geriatrics Department in partnership with Indiana University's School of Medicine. A really amazing group. Great group of individuals. We've had a lot of them
We've had a lot. You want to hear who?
Some amazing, innovative stuff.
Amazing
tell me.
work. So we've had Malaz Bustani, we've had Kathleen Unroe, we've had Meredith Green, we've had Chris Callahan. We recently had Greg Sachs on. We had Lexi Torkey, and I'm sure I missed some in our review.
We got to give IU a special plaque. The most amount of Jerry Pal podcasts.
Yeah, terrific opportunities to work there if you're interested.
Yeah, they're looking for physician faculty to join them in inpatient, outpatient settings. To learn more, go to our show notes of this episode to find the recruitment link. And on to the show. Hi, Jerry Pal listeners. Before we start the next show, we just want to do a quick thank you to the donors who've recently donated to the Jerry Pal podcast over $250, including
Elizabeth Malloy, Shinyi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, and Susan Nelson.
And if you want to donate, please click the donate button on our Jerry Pal website. And on to the show. This episode of the Jerry Pal podcast is CME eligible.
To claim credit, please go to the CME tab on jerrypal.org.
Welcome to the Jerry Pal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
Today, we're delighted to welcome back Sarguni Singh, who's a hospitalist researcher at the University of Colorado. And you can listen to her on our prior podcast on palliative care and rehab. I last saw Sarguni in Banff. I think we were painting together in painting class. That's how palliative care researchers roll. Sarguni, welcome back to Jerry Pal.
Thanks for having me.
And we're delighted to welcome Christian Furman, who's a geriatrician and palliative care doc at the University of Louisville. Christian, welcome to Jerry Pal.
Yes, thank you so much.
And we're delighted to welcome back Lynn Flint, who's been on many times as a guest, as a host, as a guest host. She is a palliative care doc and directs UCSF's Jerry Pal Fellowship. Lynn, welcome back to Jerry Pal.
Thanks for having me.
So we're going to be talking about rehab and death. This is kind of a playoff of past podcasts we did on rehab to death, talking about skilled nursing facilities, hospices, and hospitals, these transitions all between the two, the incentives that may misalign with people's goals. But before we do that, I think we have a song request. Lynn, do you have a song request?
I have a favorite singer.
Who could that be?
Lynn is a Swiftie.
I'm a Swiftie. Nothing from the new album was appropriate for today.
Is that because you don't like the new album?
We will do some supplementary materials about that. However, I like a very direct metaphor for the Jerry Pal podcast, so I thought we could do Out of the Woods, because I think it's a good metaphor for when you go from the hospital to the SNF. It's like, okay, are we out of the woods here? And it's never totally clear. And that's, Taylor's not talking about the hospital. She's talking about a relationship, but close enough.
All right. Great choice. I had a lot of fun with this. For the pre-recorded version, you'll hear I went a little crazy.
Great.
It was a lot of fun. So here's the live version for YouTube. Looking at it now, it all seems so simple. We were lying on your couch, I remember. You took a Polaroid of us, then discovered the rest of the world was black and white, but we were in living color. And I remember thinking, are we out of the woods yet? Are we out of the woods yet? Are we out of the woods? Are we in the clear yet? Are we in the clear yet? In the clear yet? Good. Are we out of the woods yet? Are we out of the woods yet? Are we out of the woods? Are we in the clear yet? Are we in the clear yet? In the clear yet? Good.
Awesome.
That was so good.
What an interpretation.
Well, I saw there was a version of Taylor Swift doing it live on solo piano at the Grammy Museum. It was incredible. I mean, she is an incredible artist. Hit every note perfectly. Didn't make a single mistake in the piano. It was an amazing performance. Very emotional, and she tells a little story about it too. Check it out. We'll put a link.
Well, this podcast is not going to be talking about Taylor Swift.
I'm keeping my mouth shut.
Yeah, despite Lynn's. So we're going to be talking about rehab and death. But before we do that, Lynn, you wrote a paper, New England Journal?
I think so, yeah.
JAMA, New England Journal? One of those two?
Yeah.
On rehab to death. We've had you on a podcast too. We'll have a link to that on our show notes. But can you just briefly describe what is rehab to death? Would you be willing to do that?
Absolutely. Alex and I worked on that paper together. It came from when I worked in a short stay SNF as a palliative care doctor. Didn't know much about nursing homes, and I saw all around me people with palliative care needs coming out of the hospital really sick, thinking they were out of the woods, going to get better, and realizing they maybe weren't going to get better, maybe having something happen that put them back in the hospital. And I then came to be an inpatient palliative care consult attending, and I saw those people on the other end coming back. And so I got really interested in that cycle and what are the policy drivers and clinical drivers that lead to that happening. And so that's what that original paper was about.
I mean, it feels like we see this cycle a lot. People being discharged to rehab, they come back to the hospital. This happens multiple times. Is this common, Christian or Sarguni?
Yes. I mean, I used to see this a lot at the VA when I would discharge patients to the nursing home with hospice. Actually at this time, we knew they were dying and they still came back, because of the payment systems and the way our system works that when they get to the nursing home, they say, okay, you want to die at the nursing home, the Medicare hospice benefit, you have to pay for room and board, or you can stay here free and use your skilled Medicare benefit. And of course, people choose free and then they don't get hospice and then they get worse because they're dying and they get sent back to the hospital. And it's this vicious cycle. And so trying to break that cycle is the purpose of all this.
Yeah.
Yeah, it feels very common. I primarily work on our inpatient oncology service as a hospitalist and also our ACE service. So taking care of generally older adults with multiple chronic conditions and cancer. And some of the studies that we looked at using like SEER Medicare, estimates around 20% of patients use the SNF benefit with readmission rates in the high 20%, 30%. But I sometimes think about the surprise question, would you be surprised if someone passes away within a time frame? And sometimes my hospice colleagues and I are like, nobody would be surprised if this patient came back from the SNF, given how sick they are when we're sending them there. So I feel like it's quite common.
And then just for my own clarification, when we say SNF, are we talking about nursing home? What are we talking about when we say SNF, those skilled nursing facilities?
So the nursing home is just two sections to it. One is the skilled part and one is the long-term part. People can just live at the nursing home, but the SNF, the skilled nursing facility, is really, it's a benefit. This is a policy issue. It's what Medicare pays for, and Medicare pays for the skilled nursing benefit where you have to be skilled, and they pay for 100 days or until you meet your maximum rehab potential. So sometimes that's only like a week or two they pay, and they pay 100% at the beginning, but they only pay 100% for 21 days. And to be skilled, usually people think of skilled as physical therapy, occupational therapy, speech therapy. But what we figured out in writing this paper and talking to our colleagues that have done it other places, you can skill people for end-of-life care. I mean, end-of-life care is complicated nursing care. It's skilled nursing care. So you can skill people for feeding tubes or IV antibiotics or IV fluids, but you can also skill them for end-of-life care. And that's what we're talking about is like, hey, there's a way to do this. And you can still use your SNF, the skilled Medicare benefit, and dying patients.
Yeah, essentially it's a short-term bridge to have people go back into the community, whether they were living at home or in an assisted living facility. It's for people who need continued care, whether it's rehabilitation care, nursing care, for a period of time. And so that's the intent when we send them out of the hospital, is that you'll be there for a short while and then hopefully get back to your usual routine at home.
Yeah, and a skilled nursing facility, they do skilled nursing care, so people with skilled needs. They also do long-term care, and then they also do hospice care.
Well, there's the SNF part, which is the Medicare unit, which is like what we call rehab when we send people out of the hospital. Then there's the nursing home part where people might live for long-term care. They're paying for that out of pocket or maybe Medicaid, for example. And hospice can come in, an outside agency can come in and help support those patients while they're living in the nursing home. But traditionally, hospice does not concurrently care for people who are in the SNF part, in the rehab short stay part of the nursing home.
And why not?
People are pretty afraid of double dipping.
And that's the crux of this whole.
So what is the issue there?
That's the crux of it.
What's the crux, Christian?
The Medicare hospice benefit does not include room and board at the nursing home. So patients have to choose. Medicare pays for rehab and Medicare pays for hospice. They don't pay for both at the same time. And so the poor patients are having to choose, and the families are having to choose when they get to the nursing home, pay us. And what happens is, since the Medicare hospice benefit does not include room and board, the families, when they get there, if, I ordered hospice, they were supposed to go to the nursing home with hospice, die at the nursing home, and then they show up back in the emergency room, short of breath, and they die in the emergency room.
Yeah.
And it's because they never got hospice, and they didn't get hospice because the nursing home says, pay us $100 a day, $1,000, however much it is for room and board, or you can stay here free and use your skilled Medicare benefit.
Yeah. So
so we figured out the workaround. And
Well, before we get to the workaround, so I'm just going to make sure that I get this straight. So Medicare will pay for a skilled nursing facility for things like rehab, skilled needs, fully for 20 days, 21 and longer. There's going to be a copay up to 100 days. But they won't pay for concurrent hospice care during that time. And hospice is not a skilled need. So they can't do that. And Medicare does not pay for long-term care. They will pay for hospice. So you have to figure out how you're going to pay for that long-term care here, Lynn. Medicaid, if you're Medicaid eligible. So if you don't make a lot of money, don't have a lot of assets, you can get Medicaid. They'll pay for long-term care. And then you can get concurrent hospice care while they're getting room and board through Medicaid.
Yeah.
But from a skilled nursing facility perspective, so now we're talking about a different point of view, the incentive, it feels like, from their perspective is they don't like those Medicaid or long-term care rates, which are significantly lower, probably around here, $300 a day, versus like $600 a day for skilled nursing facility rehab or other skilled needs. Is that right?
That's correct.
That's right.
So
it's a mess.
So there's an incentive. Well, let me get this. So what's the incentive of the hospital?
The incentive to the hospital is to decrease the length of stay for a patient. So to send patients to the SNF as soon as they're ready to go.
All right. So just get them to rehab. It's the quickest thing. What the incentive for the skilled nursing facility is what?
Is to
Medicare.
Have the patient on the Medicare benefit for as long as possible from a financial standpoint.
And that's that skilled nursing rehab benefit where 20 days is fully covered. More than that, there's a copay up until 100 days.
Right.
Is that right?
Have them on the SNF benefit for as long as possible and then not be on anything other than the SNF benefit.
Get them
for
out
as
of
short
the SNF.
as possible. Right. Yeah.
How about from a patient family perspective? What's the incentive there?
They just want their family member in a good, comfortable place and die comfortably and not be all these transitions of care they do not want.
Or I would even also say they're getting out of the hospital fast. They're not walking well anymore.
Yeah.
The doctor told me I'm going to go to rehab and get stronger.
Yeah. So their goals may be, I want to get stronger. I want to get better. I want to get all the care you got.
Yeah.
Yeah.
And I think a SNF stay also can relieve caregiver burden significantly. Just even a week or 2 weeks can be so meaningful for family members who are struggling to care for the patient at home. So it can feel like a reprieve as well.
And
I think,
Oh, go ahead, Christian.
I think they just want honesty too. If they're not going to get better and they are actually dying, I think they would like somebody to tell them that. Go ahead, Alex. What are you going to say?
Yeah, that's what I was going to say. And that if you if the hospital clinicians were honest with the patients about their chances of recovery, they might make different choices. On the other hand, like for a lot of them, it's not all the way one way or the other. Like you're going to go to rehab to get stronger, as if you're absolutely going to get stronger is the interpretation the patient and family take away, or you're not going to get stronger in rehab. We don't know that too. There are some patients who surprise us, right? Who we think, oh boy, I think they're dying. I'm worried about sending them to rehab, but boy, they really want to give it a shot. And maybe, there is a world in which maybe that happens. And I hope that does happen, right? Like we hope that they're able to achieve that goal.
Mm-hmm.
And
yeah, there's so much hope. Yeah, there's so much hope in this transition. I don't mean to interject, but because I talk to patients in the hospital all the time, and I try to do what you said, Alex, is lay out what it looks like, the concerns I have, what the data shows, and still, you then hear stories about times when people were told they wouldn't survive this hospital stay or this chemo wouldn't work, and then they just want to try, and that's really important to them. And so it's tricky, and then you add on the fact that if they don't choose the SNF benefit and they need to stay in a nursing home, they have to pay room and board. For them, it's kind of a no-brainer. One, this is the path they want to go down, and then it saves them money. So we definitely need to improve our counseling for when patients go to SNF, but I think there's just a lot of hope, and people oftentimes want to see what their bodies can do. And the other thing I will say is there's a lot of limitations in the Medicare hospice benefit that people just are not willing to accept, like not being able to see their cancer doctors or not being able to get a blood transfusion or come back to the hospital if they get sicker. And so these things compound into kind of the expectations patients have when they go to the SNF from the hospital setting.
And I think the other thing they want is honesty about just and education about the whole process. Is I had a neighbor, this is my neighbor, a friend of mine, and she really wanted her mom was dying, to go to the nursing home and die at the nursing home with hospice. The nursing home never offered her hospice. She was willing to pay room and board, but no. So that it happens so much.
And that's because the nursing home will make more money if they admit her under skilled.
Yes. And they didn't even offer hospice. And so hospice really, it depends on the nursing home, because I think you said, there's different sections of the nursing home. One is the hospice part. Some nursing homes do not know how to do hospice. And this poor neighbor friend of mine's mom did not have good end-of-life care because she was not in a facility that could really provide good palliative care. But hospice could have if they would have consulted hospice. So she was very, very mad about it.
Yeah, we're seeing that a lot more, where nursing homes will not take people under hospice, where nursing homes will say, oh, we do our own comfort care here, which is really just skilled nursing with not really doing rehab, but billing for that level of care, where they're not providing an interprofessional expert team who can manage people at the end of life, that hospice care. I'm hearing from hospices too, like they're seeing this happen more and more, where the goals are very much aligned with hospice, but hospice can't go into that nursing home.
I think the new payment model might be influencing that to a degree, where nursing homes, SNFs in particular, aren't incentivized by the number of rehab hours they deliver anymore. And instead, it's based on patient complexity and comorbidity. So they can get reimbursement for taking care of a really sick person under the SNF Medicare benefit. And they don't have to provide rehab to the same extent. And by rehab, I mean physical therapy, occupational therapy, or speech therapy to the same degree that they had to before this payment model switched.
And this payment model is the patient-driven payment model, PDPM?
Yep.
PDPM.
Yeah.
Age-driven payment model.
Yeah.
And that payment model says they don't have to make progress, right? They don't have to improve. They just, used to be they had to improve. If they didn't improve, then rehab was over. But now they can just be, Sarguni, you understand a little bit better, but they just have to be maintained, right? I think is, and
they have to be complex. They have to be complex. A lot of the nursing homes have like people whose job it is to make sure we're eking out all the complexity.
Yeah. So if you had a choice between a oral opioid or an IV opioid, you can maybe increase complexity, even though you can swallow things, by thinking about IVs instead, or talk about that skilled wound care for somebody who maybe just doesn't have a lot of Yeah.
Or you change the doses regularly, that kind of thing.
Lynn,
Yeah.
so you wrote a great article in JAGS, Rehab and Death, Improving End-of-Life Care for Medicare Skilled Nursing Facility Beneficiaries. I wonder if you can put this in context, because you did a good kind of summary about a patient. I think it was a hypothetical patient.
Yes.
Mr. Z. Could you just kind of give us a brief overview of who was this Mr. Z? Because I think this puts it all into context.
Sure. And I think several different clinical scenarios came up, and there's a lot of different ways that the incentives push things maybe in the wrong direction in a lot of different clinical scenarios. So this is just one example. A 80-something-year-old person who's got multiple medical problems, predominantly congestive heart failure, gets hospitalized for heart failure, is there at the hospital for a week or so, and during that time gets treated for heart failure, but also is kind of in bed for the entire week, can't really walk well at the end of the week, and so gets discharged to SNF, ends up being at the SNF for rehab, because of course this person came from home, wants to get stronger, then gets sick again, gets another heart failure exacerbation, goes back to the hospital, comes back to SNF because now he sort of belongs to the SNF. Happens a couple times. And then, the last time this person lands back at the hospital, he says, it's not in me anymore. I don't really want to do rehab anymore. And the question is, well, okay, what do we do? How do we line up all of this person's benefits and services to help support him now?
Yeah. And what I'm hearing, Sarguni, is this right? So now we're in this tough bind where there's not a payer source for long-term care for him,
Right.
unless he's Medicaid. Hospital still wants to get him out quickly. You're thinking about home, but if home isn't an option, where do we go from here? Am I hearing that correct?
Yeah, definitely. I think during those repeated transitions, I imagine a hospitalist trying to approach Mr. Z to be like, this is your second readmission, and Mr. Z kind of declining hospice for the reasons we mentioned. It might not be aligned with his goals. There's limitations in the benefit.
May want to come back to the hospital, may still want, these interventions.
Yeah. And a lot of people I hear are want to come back if it's a quick fix, if it's a UTI, some antibiotics that turns around in 48 hours, which is, I understand, but sometimes we can't really predict what's a quick fix, versus what's not.
Yeah.
But then at the end here, his values and goals finally align with hospice. And we would essentially say we have to either see if we could safely send you home with enough social caregiving support if you have that. And if not, then you would need to go to a nursing home and pay for room and board out of pocket. And whether that is spending down his savings and then filling out a long-term Medicaid application. Rarely people have long-term care insurance, so that might kick in. But that's kind of what we would be talking about from the hospital standpoint at that juncture at the end.
And that nursing home may not want them because they'll get paid at a significantly less rate than they would if that bed was occupied by somebody with getting skilled needs. Is that right, Christian?
Yeah. And the thing is that we came up with a solution, and I think that's what this paper was really, and really there's the workaround. We have a workaround now that what we're doing now is but you have to really understand the system to make it work. And this paper was a way to tell everybody our workaround and also to make it.
Okay, let's talk about the solutions, because the first one is actually not a workaround. It felt more like we want some more data. And you mentioned something called the Government Accountability Office. Is that still there? Well, let's not get into that. GAO. What was the very first recommendation? Why is it GAO, Government Accountability Office?
The GAO is essentially a nonpartisan governmental entity that provides reports to members of Congress. And we want more information about the use of the Medicare SNF benefit in the last 100 days of life for Medicare beneficiaries. We just don't have up-to-date data on who is using the benefit, what are their characteristics. And that's very important information for us to know as we counsel patients in the hospital. And then there's all these new hospital at home models and SNF at home models. And so that information we think is vital to better understand who is currently using the benefit in 2025 and what are their outcomes.
And there hasn't been a report like this in many years. Yeah.
Yeah. And the whole point of the SNF benefit is really rehab, physical therapy, occupational therapy, speech therapy. But what we think is happening is they're all dying. And that's not the purpose of the benefit. It's for rehab, really. It was really meant to be rehab, but we're trying to like make it do other things. So let's just be honest about it, instead of just trying to do this workaround. So that's what I think the data would help.
Okay. So number one is data. Number two is what's the workaround?
Well, the workaround that we're doing now is we're skilling people for end-of-life care. And we did talk to CMS and got official approval, and a lot of nursing homes are doing this, is it's complicated nursing care, and we are skilling people for complicated nursing home care. So they're at the nursing home using their skilled Medicare benefit, but for end-of-life care. You're not torturing these people, making them walk up and down the hall and do rehab and physical therapy when they're dying.
Go ahead. No, continue. Yeah. Keep going.
Well, is it complicated end-of-life care? Because as I heard from you, these nursing homes have 100% turnover rate in their nursing staff. Their training and skill set in end-of-life care is not hospice. I actually asked Carl Steinberg, an expert around nursing home care. He's part of Cal TCM here in California and nationally involved, kind of how he thinks about this. And I think his biggest concern is, like, even when we think about like this PDPM kind of workaround, is that these individuals, these nursing homes, like, they get paid for skilled need, right? Like, they would certainly take this as a way to get $600 versus $300 a day and provide the exact same care as they would have at $300 a day, because they don't have the training or skills like hospice does and the interprofessional team. They're just billing more for less. Thoughts on that?
So part of what our model was is that you'd have to have these quality measures in place. You'd have to show that you can have 24-hour access to IV, opioids. You'd have to have a chaplain, a social worker, an interdisciplinary team, or else you cannot get this benefit.
But I thought wait, that's the third one, right? The second one is the workaround under PDPM, which does not require any of that, right?
And the second one is a hybrid of having palliative care and skilled care at the same time.
Yeah.
I mean, there's, maybe Sarguni, you can kind of show, there's like 3 different pathways that we, kind of put out there as a model.
Yeah.
Yeah, it was a great figure.
Yeah.
Everybody check out the figure in JAGS.
We'll have a link to it on our show notes.
That was Lynn's creativity and artwork in making that. I think our second recommendation was to figure out ways within the existing payment model to encourage nursing homes to bill for palliative care principles that they are delivering. And so that was kind of the main recommendation for the second aim.
Do you think they can deliver that?
Yeah, this is the TLDR version of what Eric said earlier is, well, okay, the nursing home can bill for this skilled palliative care need, but are they delivering skilled palliative care?
Good question.
I'll be honest, in my recent experience with it, having had a nursing home that refused to take somebody under hospice care, but said, oh, we can do palliative care. He will be under comfort care, which is not a thing. It's skilled. And it was terrible. It was the hospice that the person could have been in was amazing. And it was a absolute failure system. And it was just about a money grab because they would make double the amount under.
And so, there's definitely the state, there's reviewers that review these nursing homes for their, to make sure they're up to snuff for their guidelines. So my sense is that if we're saying, okay, we're going to provide this, that yes, you can use the skilled Medicare benefit for end-of-life care, then the surveyors have to know these are their criteria for end-of-life care. You have to have a doctor, nurse, chaplain, social worker. You have to have an emergency kit that has morphine in it. You have to have the conversations and all the details. And really holding the same standards that hospice is held to, right? That you have to have these to be able to have Medicare pay for hospice. You have to meet these criteria. For Medicare to pay for the skilled rehab, you have to meet this criteria for end-of-life care. So but right now it's nothing. And so I think if we actually are being honest about it and like, okay, we're letting this happen, then these are the criteria that you have to meet. And maybe if you can't do it, then you have to let hospice in and let them do it. And like in Louisville, we have certain nursing homes that we know do a good job and certain ones don't for end of life care. And we make sure they go to those certain nursing homes. And those nursing homes have palliative care doctors that come and hospice doctors.
It's interesting. What we're seeing is people want them on comfort care, which is skilled care for 20 days.
Why 20 days?
Why 20 days?
Well, also, can I just also point out, I think another piece of this is that policy change is hard. Certain things have to be, you have to have a policy window to make a major CMS policy change. I'm not going to comment on whether we're in that window or not at this minute in time. And we were talking about this as a way of how do we use the current existing policy to improve what we think is already happening. And so I think that was a big part of our initial discussion here. It was like, okay, well, we have now a way to bill on complexity for SNF.
Yeah.
What are the things we need to add in there to make it so that decent end-of-life care can be given under that
What do you think
policy?
The things to add into there is?
Well, all the things
criteria.
was listing.
Criteria. Like you have to have, so it's like access to opioids in-house, not that the pharmacy's, half an hour away. So you have to have an emergency kit that has like the comfort pack that has all the end-of-life meds on hand. And then you have to have a doctor, nurse, chaplain, social worker that's trained in palliative care. And that's the big things. Maybe there's, I don't know.
Yeah.
We have
Sarguni, anything else that you'd add to that you'd want to see?
Well, I guess a little bit of a tangent, but I think that patients need to be better prepared in the hospital that this is the kind of care that they can receive in the nursing home, as Christian is saying, because there's such stigma. Like you come from the hospital, you're monitored, you have a nursing alarm, everyone's there, you get a lot of attention. Then you go to this nursing home setting where there's less monitoring, there's less people. And so then if you start receiving, end of life care in the nursing home, patients can be like, well, they didn't talk about this with me in the hospital. Like you're just giving up on me and they never did this then we never had these conversations in the hospital. So I think it's super important to start this conversation in the hospital setting and to set expectations so that when patients do go to the SNF and maybe don't improve the way that they want to, if the care is transitioned in that setting, it's not necessarily something that's brand new to them.
And can I ask that the third big recommendation was a demonstration project?
Yeah. And this is the pie in the sky, blue sky, best possible option. Well, in defense of the second option, I like it as a workaround within the existing system because what we have is very broken. The second option,
I'm not with Alex.
Eric's not on board.
I've seen it go awry, and I don't like it.
You're a cynic.
So I think we disagree about that. I think that this is an attempt, and maybe it's possible. One can hope that once you create the billing structure, then nurse SNFs will feel incentivized to provide a robust palliative care service that they can bill for. So once you create that payment mechanism, then it might be possible. But we should talk about the third, which is the blue sky, best possible option.
Yes. Shall I talk about it?
Yeah, what's
the
blue
third
sky?
one. You started off.
I'll start it off and my colleagues can jump in. So I'm looking at my own diagram. Our suggestion is if you have somebody leaving the hospital, you hope that some rehab's going to help them, but you're pretty worried. That surprise question is you're pretty worried things might not go well for them. They're in a similar mindset after good conversations of, I want to give it a shot at rehab. And I also see if things don't go well with rehab, I don't think I want to get caught in the vortex. I want to shift my care more towards comfort care. What we're suggesting is during that first 20-day period, people have a trial of quote unquote rehab or SNF and hospice. You can't, not just one or the other, you get to actually have both. And then that's the part where you're still in the woods. Get my reference. You can't tell, it's sort of allowing the person's giving the person's trajectory a little bit more time to declare itself. Those 20 days. We went around a lot on how many days should that be, and we decided it should really fit within the existing policy.
And the nursing home is getting paid at that higher billing rate.
That's right.
The hospital can discharge them because nursing home will accept them.
That's right.
And if there is a place for them to go because Medicare is paying for both hospice and the skilled nursing.
Exactly.
And we're honest. We're honest about what's happening.
And having hospice involved allows that extra layer of support to actually allow for those ongoing conversations to happen as we see how the person is doing.
And from a financial perspective from Medicare is the hope that despite now having to pay for both skilled nursing and hospice, so now they're also paying $150, $170 a day for hospice care. Again, a little bit more complicated, it's a little bit more upfront in the end. What's the incentive for Medicare?
They'll save money because the patients aren't going back to the hospital. Those transitions of care is where all the expenses, and they end up in the ICU sometimes, on the ventilator. And that's where there's a lot of expense. So the ER visits and the pain and suffering of the family and the patient and dying in the emergency room. So there's some existential suffering, but there's some cost that's not always just financial cost, right? There's cost to people's well-being. But the financial incentive is the decreased cost from the ER visits and the unnecessary hospital stays. And it's a demonstration project. So it'd be through the Center for Medicare and Medicaid Innovation, which is now the CMS Innovation Center. So that way they'd study this, right? Just like the hospice was a demonstration project, the Guide Dementia Project, a demonstration project. You have to try it, see what happens, study it, have the data, and then implement it for everybody, every Medicare beneficiary.
If it works.
Because there's always unintended consequences that we can't predict all the unintended consequences.
Yeah, because there are some. What would be the incentive then for the nursing home to ever take patients not on this pathway?
Yeah,
because they could get both SNF and the hospital.
Yeah, nobody would. If I was a nursing home, administrator, everybody would go through this pathway.
Coming from the hospital comes in on hospice and
you're still, this was pointed out to us. I think you are still left with the question, if the person goes on to hospice, the nursing home is then going to get that lower reimbursement rate if they keep the person in the nursing home.
And you'd still need to figure out.
And they would have to pay room and board.
Yeah, so there's still a discharge, but it's not a perfect solution.
It's still
Sarguni,
the 20 days.
Yeah. Sarguni, do you want to say more about what happens after this 20-day period?
Yeah, so I think, we talked a lot about this with Joe and Tina, who was also a co-author on our paper. And, this idea that, it's so hard to prognosticate, as you mentioned earlier, Alex, when we're discharging someone. And so then they get information that the SNF stay is valuable information that if they don't improve, that in itself is information. So at day 20, then technically patients and families would decide, do I want to go on just exclusively this hospice route? If so, then do I need to be in a facility or can I go home? If I need to be in a facility, you pay for room and board just like everyone else. If you go home, then you get the Medicare hospice benefit at home. And then if you continue to say, I want to go down this rehab path, I've improved to the degree that I thought I would, then they continue on with the Medicare SNF benefit, incurring a copay starting on day 21.
So it's really interesting because there are healthcare systems, the VA, that will pay for the room and board in a nursing facility. They will pay for hospice concurrently with that nursing home stay. And they'll also pay for concurrent care. So if they want to continue their, let's say, immunotherapy, they'll pay for that. And I don't know, is there any data that actually saves money? Because it kind of feels like it does. Those people actually utilize less in the long run. But should that be what the system looks like?
You can get, all of the above, right? And they're doing that with pediatrics, right? Where, it's a lot more flexible. But I don't have the data for that for adults.
I always struggle with this comparison with the VA and our multi-payer system. It's there's such great learnings at the VA, but we don't have a single payer system. We have Medicare Advantage and Medicare and long-term care insurance. And so that's
the real blue sky.
Yeah.
Yeah.
I think we talked with Vince Moore about this on a podcast. That was a while back now, about this idea of concurrent care.
We've definitely had a podcast on concurrent care and that it actually does save money. The question about if you pay for, in this pathway, pathway of decide I'm going to go hospice route after the 20 days. It'd be interesting to know, maybe that's another demonstration project.
It needs to have data. And I'll tell you what was nice about our model is that we don't have to get a bill passed in Congress or do anything. It's the existing Medicare model already and just use the current model and just tweak it. So it seems more doable now.
Yeah,
and I think that's super important to emphasize is like, you can create the policy change to whatever degree you want. And so if you have a more narrow, kind of concise policy build or idea that you're floating, it's much easier, I think, to get initially passed and get momentum for it than to do a wide sweeping change. And then from that, you can continue to develop other policy ideas. But it's really just getting your foot in the door and getting one change and then doing other things after that. I think that's something that I really learned over the last few years.
Well, I was going to say that's what I learned from as a clinician who looks at everything that's wrong with the world. I'm somebody who I have a lot of ideas about fixing things. What I really learned from this work, from working with 3 policy experts on this, is the first thing when you see a problem is like, let's look at what's existing already in the policy and how can we work with that? How can we work inside that framework? However weird, messed up, intricate, dysfunctional that framework is. And maybe this is why we're in this really complex, dysfunctional thing, because we keep layering things on top. But the truth of the matter, what I learned is like, let's look there first and see if there's ways we can do tweaks to what exists, because it's so hard to push through a sweeping change.
Mm-hmm. Yes. And because it's already exists. Because I was really trying to get the Medicare hospice benefit to change to include room and board in the nursing home. And they're like, we already have a benefit in the nursing home that pays for room and board. It's a skilled benefit. Just use that benefit. I was like, okay, well, let's just advertise it. I really appreciate this opportunity to educate people. It does exist now. Just use what's there now.
Yeah.
And then make sure
these were from your conversations with people in DC.
CMS.
Yeah.
So because they're like, no, we're not going to change the whole benefit. Thank you very much, but we will let you use the existing benefit and just use the existing benefit and just skill people for end of life care. But you have to have the quality there. You have to have the quality. You have to have somebody there at the nursing home making sure that palliative care is really happening.
Yeah, that's my biggest concern right now. Like, if we used current state, it's just I feel I don't know. I would love all of your do we have enough mechanisms in place to ensure that there's quality? Because let's face it, money in medicine matters. And if you're a skilled nursing facility and you have to decide, I don't have that, but I can use this workaround to get $600 a day instead of $300 a day. Let's do that, even though we can't provide that hospice care. But if we get the experts in, the hospice care experts, we're going to make a lot less money.
You mean because you have to pay the chaplain, the social worker?
Well, I don't even have that, but I'm going to get paid less per day if they're not under skilled nursing.
Right.
And to get that hospice care, the only way to get the expert hospice team is actually under the Medicare hospice benefit, which you can't have at the same time.
Yeah. So what we've done is a lot of our palliative care team members work in the nursing home. And that's kind of what you were doing, Lynn, right? You were, so consulting palliative care doctors or nurse practitioners to come to the nursing home. That's not the whole team, but it gives you more than some that they have now.
Yeah, I think there are models. And I remember when I was in palliative care fellowship, there was a model in Boston that provided terrific palliative care within the SNF. And I don't know how they charged it back then, but somehow they had a palliative care unit. Maybe it was under a bridge benefit. I'm not sure. But, and I feel like there are potentially models in San Francisco that I've heard of where palliative care has a major presence. So I'm hopeful there may be exemplars. And I agree with you, Eric. I worry about the many underfunded SNFs who might bill for this skilled palliative care, but not deliver skilled palliative care.
Yeah.
I mean, I think ultimately the nursing homes are going to behave in the way that they're incentivized by payment models. So advocating for a payment model in which you're delivering, high quality palliative care, having ways to assess and survey nursing homes to make sure they're doing it, ethically and that patients aren't being forced into hospice against their will is really important. But I think the nursing homes are reactive. Like they're behaving in a way that will get them the most money. And if we change it so that they can get money for delivering palliative care, then I'm not sure why we wouldn't think that they wouldn't follow suit with that.
Okay, let me, I know we're coming close. Can I ask all of you kind of, if you had a magic wand, you could fix kind of one thing or make one change to the current system. What would you use that magic wand on? Sarguni, I'm going to start off with you.
Oh gosh. I would like to have Medicare pay for some long-term services and supports and start providing coverage for that in some form.
Wonderful. What would that look like? What like one thing, what would that look like? What kind of long-term?
Yeah, I think it would be more like caregiving at home, like nursing aid support at home, which I think would institutionalize less people. It would look like room and board coverage for older adults who need to be in an institution. It would, potentially bankrupt the Medicare trust fund, but that's why it's my wand solution. And I think we have to figure out how to pay for that. But I do think that's an important next step as we think about how to evolve the Medicare benefit.
Christian, what would you use that magic wand on?
I love our third option, the concurrent, we can get rehab and hospice at the same time, because you just don't know. And that way you get both.
Get that demonstration project rolling. Lynn?
I think very specifically, I would really like for Medicare to pay for room and board in a nursing home for when people are on hospice.
I thought you were going to say, I'd like to hear another Taylor Swift song.
Yeah, that's what
I would like Taylor Swift to do a tour on the new album.
But you didn't like the new album. Well, that's another podcast right there. Alex, I'm going to use my magic wand on some Taylor Swift.
All right. That was a great discussion. I'll shake it off. I don't know if the four of you are ever getting back together again.
Oh my gosh, this is amazing.
Have you on again if you do. All right, here's a little bit.
Are we out of the woods yet? Are we out of the woods? Are we out of the woods? Are we out of the woods yet? Are we in the clear yet? In the clear yet? Good. Are we out of the woods yet? Are we out of the woods yet? In the woods yet? Are we in the clear yet? Are we in the clear yet? In the clear yet?
Lynn, are we out of the woods yet with hospice and skilled nursing facilities?
No,
we're not in the clear? We're still in the woods?
We're in the thick. We're in the thick of it.
Not in the clear. Not
Yeah.
in the woods. In the woods. Lynn, Christian, Sarguni, thank you for joining us on the Jerry Pal podcast.
Thanks for having us.
Thank you so much. It's always such a pleasure.
And thank you to all of our listeners for your continued support. And we'd like to do a special thank you shout out to all of our donors who've donated more than $250, including Alex, who?
Kate Mesrich, Jen Hopping, S. Ashad Abid, Michael Bordofsky, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Cassell, Victoria Brand, Susan and John McFadden, Christopher Heck, Emish Simoji, Matthew Schuster, Karen Hagan, Lloyd Woolstat, Carrie Levy, Marmy Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anand Nayak, Xin Yi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, and Susan Nelson.
And thank you for your support again.